Good afternoon, everyone, and welcome to today's webinar, Building an Effective Medicare Advantage Strategy. I'm HHCN editor Bob Holly, and I'm going to be your moderator for this discussion. Today's webinar is being recorded, and a copy of the recording plus the slides will be shared with all attendees following the webinar's conclusion. Please note your audio lines have been muted, but feel free to send us any questions you have using the question box on your screens. We're going to get to as many as we can during the webinar's final 10 minutes or so. So again, if you have any questions as our speakers are going through the material, send those our way. Before I introduce our speakers for this afternoon, I want to say a big thank you to Axxess for sponsoring this webinar and coordinating the conversation today. I know figuring out how to work within the MA framework is a huge priority for a lot of home-based care organizations today. So I really can't wait to get started. And with that, let's meet our speakers. First, we have Brian Harris, Consulting Director at BlackTree Healthcare Consulting. Brian has more than 9 years of consulting experience in home health and hospice, specializing in revenue cycle and cash flow. Brian is actively involved with HHFMA as well and other industry work groups designed to navigate the rapidly changing regulatory and operational post-acute care landscape. So he's a great speaker for our goals here today. Brian, thanks for joining us. Next up, we have Samantha Sulis, also a consulting manager at BlackTree. Since joining the company in 2015, Samantha has gained experience with project management and process improvement through her revenue cycle redesign work and related business operations within the home health and hospice industry. She has specifically led the redesign of numerous billing departments for mid and large-sized agencies, assisted clients with acquisition integrations, and payer contract analysis. Again, a perfect speaker for our goals here today. And last but not least, we have David Hoover, Vice President of Revenue Cycle Management at Axxess, the fastest growing home health care technology company around. At Axxess, David leads the company's billing, electronic data interchange, and payer management service teams. To date, David's team has processed more than 14 billion in Medicare managed care claims. That's billion with a B. Prior to joining Axxess, David served in leadership roles at a leading data analytics company where he developed new processes and systems focused on payment accuracy for health insurance organizations. He has also served as a regional director for a large healthcare organization, and really his bio goes on and on. That's just the tip of the iceberg. So again, fantastic speaker for our goals here. Brian, Samantha, and David, without further ado, I'm going to go ahead and hand things off to you. David, take it away.
Great. Good afternoon, everyone. We're going to start off, again, the topic we're going to be talking about is building an effective Medicare Advantage strategy. And the first part, we'll talk about some of the objectives of this presentation. Brian, if you want to go ahead. So a couple of the learning objectives, first we want to review the current Medicare Advantage plans and how their growth and additional services have been over the past few years and currently at the current situation to date. We also want to build a general understanding of how the model, the Medicare Advantage business model works, and also how the incentives work for a Medicare Advantage plan, just to make sure that we're getting in line with how that business model works and operates. But we also want to discuss some contracting strategies with the plans, and we also want to consider some of the impacts that it has on operations and probably discuss a few of the potential changes once you move into a true strategy for Medicare Advantage plans. So let's go to the next slide. Okay, so just a quick overview to make sure everybody's on the same page. Talk a little bit, Medicare Part C, which is a Medicare Advantage, was formalized in 1997. Originally, it was called Medicare Plus Choice. It was renamed to the Medicare Advantage once it allowed prescription coverage in 2003. And basically what Medicare Advantage is private insurances offering coverage for Medicare beneficiaries. It's a way for the Medicare program to shift the risk of the delivery of healthcare into the private sector. So Medicare plans must cover Part A, which you can see on the right-hand side is hospital insurance or institutional claims. And Part B, which is professional coverage, or what we would consider medical claims, your physician services, those type. Also, there's Part D, which is your prescription. And then Part C basically marries, you have to cover the Part A and Part B, but most plans, and you'll see in some of the information, cover Part D also. In addition to this, Medicare Advantage plans can provide additional services, and most of them we see vision, hearing, dental, and preventative services, but it's expanding greatly, and there's all kinds of things that are being added as Medicare Advantage plans get more efficient with their delivery of services. So let's talk a brief moment about just how Medicare Advantage and the enrollment has grown over the years. We continue to see this steady growth all the way up to 2020. And you can see right now more than 1/3 of all Medicare beneficiaries are now under a Medicare Advantage program. Last year, the Medicare Advantage grew almost or a little bit over 9%. Which was actually a little bit above average, but on average, it's growing about 8% a year. So tremendous growth and steady growth as more and more Americans are looking towards Medicare Advantage as a good solution to their Medicare needs. By 2030, it's expected that a little bit over 50% will be under Medicare enrollment. And so it's a continuous thing that we're all going to have to deal with. This is going to be a continual model for healthcare delivery in insurance and risk bearing for the private insurance companies. One quick note, 19% of all the enrollees and plans are offered by employers, and that may be something that some organizations aren't familiar with, that not only is this an individual plan, but it's also an option that's offered by employers to supplement and help provide benefits for their employees. Let's look at the next slide. Talk real quickly about some of the things we talked about the expanding services that are out there. You know, there's a requirement that Medicare Advantage programs cover A and B, and most of them cover D, but then it gets very creative after this, and you'll start seeing that right now, as of 2020, about 79% of the programs cover eye exam, 77% cover telehealth. I know that's a very important one right now during the pandemic. You know, Medicare, that is still not a covered benefit under Medicare, but the Medicare Advantage programs definitely have it. Dental benefit, fitness benefit, hearing aids, all in that 70s to mid 70% range. And then we're starting to get into things like over-the-counter benefits like medications, meal benefits, transportation, and then some new ones, bathroom safety, in-home support, and then we know hospice carve-in eventually we get there. I know there's still some discussions planned to start next year, but you know, I think what we're seeing with these Medicare Advantage plans is not only are they looking at, and we'll see as we develop a little bit more into the program, we're looking at ways to keep their population healthy. So that's part of their management component of it, is providing these additional services. You know, transportation, meal benefits, you know, those are some things that we've seen historically, you know, make a big impact on the level of care that's needed or required for an individual. If they can't get to the doctors, if they can't get to their pharmacies, then there's a problem. That, you know, transportation and meal benefits definitely help improve the lives and the healthcare of individuals. So one thing I wanted to, you know, this is a big map with a lot of colors, but wanted to talk about, you know, Medicare Advantage is definitely a local situation, and we'll talk about it. Actually is contracted based on counties, and we'll look at that in a little bit, but wanted to kind of give an overlay of how it's distributed amongst the states. So right now, the highest Medicare Advantages shares are Oregon, Minnesota, Wisconsin, Pennsylvania, Florida, Hawaii, and Puerto Rico. But 31 states have a greater than 30% Medicare Advantage program penetration. And then in 180 counties, that accounts for 10% of Medicare. More than half are Medicare Advantages. So even in those counties where there's a significant share of Medicare beneficiaries, most of them are utilizing Medicare Advantage programs. You can see the distribution. Of course, you'll see the red in very high populated areas. And then you'll also see in the blue, again, the middle of the country where it's less populated, you won't see as many Medicare Advantage plans, but that's also probably because you don't see as many elderly also. It kind of mirrors what's going on with our populations and where we see aggregation of Medicare individuals. So that was a quick overview of Medicare Advantage and where we're at. I kind of want to move into the reimbursement and the modeling. I think it's very important to understand how Medicare Advantage programs make their money, how their business models are approached, how they come up with their rates, because I think it's very important to align yourselves to those business models. I think it makes it easier for them to understand our delivery of care and what we're doing and how we can help them and partner with them. So basically, Medicare Advantage plans are paid a fixed or capitated amount per beneficiary. And how that's determined is it's basically called a bid to benchmark approach. On a county level, and this is again what I was telling you about Medicare Advantage plans, it's a very local situation. County level fee-for-service cost data, basically an average or a base rate is calculated by CMS. And these benchmarks are set. And usually there's, in the urban areas, there may be like a 95% of the average that's utilized, or 115% in the rural areas. And usually that's because its access to healthcare is a little bit more difficult in the rural areas. So they put a little bit more weight in the rural areas. And then that becomes the benchmark. So plans submit bids or estimated costs to cover both Part A and Part B for each county. And that's how they started getting awarded these capitated amounts per beneficiary. If the plan bids is below, or the plan bid is below the benchmark, that means the base rate plus a rebate is used to lower out-of-pocket or increase benefits. So that means that the plan submitted something that was less than what they thought the fee for service was going to cost Medicare. But what Medicare Advantage does is it puts it back into benefits for the individual. So that's why you're seeing a growth in all these different types of services. Again, one of the part where they're taking the fixed or capitated amount, they're bearing that risk of those patients, so those Medicare beneficiaries, then they're trying to make sure that they are as healthy as possible. We'll see some things out there that show it, but the way that they're doing that is starting to introduce different types of programs that help create healthy environments for the Medicare beneficiaries. Now, if the plan bid is above the benchmark, then it's a base rate plus a premium. And so basically some of that is being pushed down to the individuals. When Medicare Advantage first started out, we saw more types of plans having additional premiums because there was additional coverage. But now, as we move into a more mature market, we're seeing much fewer and fewer that are actually are charging a premium to the Medicare beneficiaries. So that basically sets the original capitation rate. But just to make sure that you understand, there are risk adjustments for each one of these beneficiaries, each individual beneficiary based on disease or demographic factors. So not only once it gets covered as a covered life under these Medicare Advantage plans, they take a look at additional things like multiple diagnosis or that may be affecting, diabetics may have a higher risk, so they're getting paid a little bit more. So you see that in the benchmarks. It's called a risk adjustment. And also, in addition to that, incentives or bonus payments are given, and it's based on quality performance of the plans. And just like we're based on this, star ratings become a key component. But those performances are based not only on that, but it's clinical, operational, and patient satisfaction. So those incentives and bonus payments can become a significant part of the business model for them. And just a quick note, Medicare Part D, this is only for Medicare Part A and B. Medicare Part D has the same approach, but it's a separate calculation. So these Medicare Advantages programs are getting capitated rates for A and B and also Part D. All right. A lot of information, so I try to make a visualization to make it a little bit easier. The first scenario we talked about where the bid is less than a benchmark is the top one, the top line. So you get a base rate plus any risk adjustment scoring. So basically the premium is 0, and then based on quality ratings or star ratings, you'll see the rebate can be 50 to 70% of that difference. So basically if the bid was less than a benchmark, if they had a 5-star rating, they could get 70% of that back to them. Now, those are the ones that also have to be put back into the Medicare beneficiaries. So through either additional services is usually where that shows up. And then if you have the second scenario, the bid is greater than the benchmark, you still have that base rate, you still have the risk score, you have some premium that's paid by the enrollee, and then any risk adjustments based on some of those factors, whether it's rural or urban, and then that becomes the payment to the plan. So not only are they getting money from Medicare, but they're also getting money from the enrollee also. So let's talk a little bit about those Medicare Advantage reimbursement models. And I was talking about aligning and making sure that they're moving towards a healthier beneficiary and lowering those costs. So one of the statements that you see out there, it's basically the highest quality of care at the lowest cost. And that basically sums up what they're trying to do. And the way that they do some of this is by provider payment models, more efficient models of care. Some of this, becomes care management. This is why we have to go and get authorizations of care and things like that. Proactive risk management. A lot of this is starting off when they're starting to look as soon as the Medicare beneficiary lines up and you're starting to see potential risks that are out there. They're becoming better at modeling or managing those, and you'll see some services like the meal plans and the travel or the transportation that becomes part of this risk management component. Also talking about member engagement and management, that's something, a key component while they're measuring client satisfaction or their patient satisfaction. That becomes a key component to their scoring and their quality scores and their star ratings. So that becomes the highest quality care that they could possibly get is satisfaction. So to the right-hand side, a couple of things that I wanted to point out, some examples of how this is working. So Humana had a program that they did and moved to a Medicare Advantage value-based care program, and it was called Humana Bold Gold. And they took a bunch of communities, I think there were 7 at the point when they tried this a few years ago, and they did it over a several-year program, but they also started watching and measuring unhealthy days. And so that's a new measure that people, really don't look at because we're used to delivering healthcare to a problem. They started monitoring how many problems they avoided. So, and some of the stats that we found, or they found by doing it this way, they reduced the cost of care, and that's based on a Medicare fee-for-service, about $3.5 billion in those 7 communities. The members visited the hospital less. That's 27% reduction in admissions and 14.6% reduction in ER visits. Again, hospitals being one of the most expensive points of entry and delivery of care that you can have. So monitoring that and reducing that is one of the key components of Medicare Advantage management. Physicians were delivering better care. So their HEDIS score, and we'll talk a little bit about what a HEDIS score or what HEDIS is, went from 3.1 to 4.44. So a significant jump in that rating. And then members receive no more preventative care. So again, this is one of those risk management components, receiving more screenings like cancer, osteoporosis, blood sugar, all those types of services that again are more talking about prevention and healthier days than they are actually acute care models. Also, there was a 2017 publication by the Health Services Research, or HSR. It was sponsored by CMS, and it was performed on 9.9 million beneficiaries in 3 states. And Medicare Advantage outperformed traditional Medicare 16 out of 16 quality measures. So that's significant. So the point that I'm making is that Medicare Advantage plans are very serious about highest quality of care at the lowest cost, and they are building and they're getting better at it. And we've seen that, and you're seeing that in the growth of their numbers and the increase of their numbers and adoption. It's becoming much more of an option for people that are qualify for Medicare. So talk about some of those ways that they actually manage or lower the cost. So provider payment models is one of the main things that they do. And we see different payer models that are out there. Of course, you have the fee-for-service model that's standard out there. But most of the time you're looking for a bonus model. Again, this would be a fee-for-service plus you get a bonus payment that's usually associated with quality measures. Again, this is them aligning their providers with their own incentives. So if they can align their providers that are providing the care with their alignment, then of course they should get better quality scores, which will help them get their bonus payments. Limited share, this is where they're starting to pass some of the savings down to the providers. And again, it's one of those things, it's a little bit of the risk-bearing model. If they can go in and say, if I can lower your first-time payments, but give you a back-end bonus based on some sharing, then we're both at risk. We both have the right incentive to do the right things. Limited value, which also adds coordination. So this is where you have health systems starting coordinating care, getting involved with the individual and making sure that those types of services that we normally have not seen are now getting seen. And then the full global value, which is full capitation. And again, you have to, these are usually for big health systems that have a wide range of services that are out there. Okay, let's go to the next. So let's talk about the reimbursement models. We're talking or continue to talk about the reimbursement models. Here's some of the 5-star ratings and some of the organizations that actually perform the performance ratings. The things that a Medicare Advantage program is rated on are member experiences, customer service, plan performance, chronic conditions, and staying healthy. And the one thing that I wanted to just mention is very much in line with what we do in home health and home care. So, those chronic conditions, staying healthy, customer services, member experiences, all those kinds of things are very much in line with what we monitor ourselves. Prescription plans are on 4 categories: member experience, customer service, plan performance, and safety and pricing. The 3 main organizations that monitor and measure these different categories is the NCQA, and then the AHRQ, and then the Medicare Outcome Survey. So the NCQA is responsible for the HEDIS measures. All right, let's go to the next. So I think this might be my last slide, but I just wanted to make sure that everybody understood that they have access to this information. So every month, CMS reports on the Medicare Advantage enrollment by month. The link is here, and you'll get a copy of this. So you can go and look at the individuals. You'll see these monthly enrollments by plan, by state, by county, by contract service area. So when you're starting to build some of your plans and your strategies, you're able to see what's in your market by looking at this information that's there in CMS. So just wanted to make sure that that you understand that you can get this on a monthly basis. And yep, I think this one finishes up myself, you know, and we'll move over to Brian and we'll talk about some of the contracting with Medicare Advantage plans. Or I'm sorry,
Thanks,
Samantha's
David.
going to do that.
That's okay. That's all right. Thanks, David. Well, as we just learned, Medicare Advantage is fast expanding their benefits offered, and we're seeing some rapid growth. So in this next part of the webinar, we wanted to provide you with some strategies for contracting with Medicare Advantage plans. I know that this is something our clients are always talking to us about. What are the best ways to work with these plans, negotiate the most favorable rates and conditions. So that's what we're going to go through here. What we first want you to start with is assessing your costs and margins internally so that you have a good understanding of what you want out of the contracts that you negotiate. What are good rates for you? So some good practices here are, first, assess your cost by location. We just heard from David that, you know, those Medicare Advantage plans are looking at it at a county level. So we know that costs can vary greatly across the state, across the country. And we also want to look at it by discipline and the type of clinician that's performing that visit. We know that an RN is going to be more expensive than an LPN. So when we're comparing that to the rates in which we receive from these contracts, that's good information to have. If you can, it's great to factor in the additional cost that's associated with different procedures and protocols that we need to put in place specifically for MA plans. Brian is going to speak a little bit later about some of the operational considerations for managing these plans internally, such as authorizations. That's something that we don't have to actively manage with traditional Medicare right now. So if you can, what are the costs associated with that, and build that in. Once you have that information, we want you to analyze the profitability on a contract by contract basis. We want you to start by calculating your weighted average revenue per visit for each contract by knowing your rates, knowing your resource mix that's managed for that payer in those given locations. And that's going to be able to give you information on your annual profit and loss by contract, and that gives you a good jumping off point to say, what contracts should we renegotiate? We have our largest loss here due to the volume and just the rates that we have and the profitability we're seeing, so maybe we should start with this contract. Another analysis on the side of that is, can you look at your non-admissions and see what payers you're often turning away in certain markets if you want to start the negotiation process with a new payer. So we have the profitability down by contract. We know what our margins currently are, and the next step is to determine what we want our desired margins to be. And we challenge you to look at this compared to target cost as well. We don't want to be asking for these astronomical rates or expecting that we need to receive those to turn a profit, because we have high costs. So look at what your target costs can be by building in some efficiencies internally if you think they might be a little bit high right now, and determine your desired margins based on that information. Look at what is a preferred margin, what's an accepted margin, discouraged, not accepted at all, so that you are well informed when going to the table, or in today's environment, going to the Zoom with these different payers and working out the best conditions for you. And lastly, knowing what your value is. This is what we're going to jump in next. David talked a lot about what Medicare Advantage plans are looking for, what their goals are. So knowing some of the value that you can provide to the MA plans is also going to help you throughout this negotiation process. Okay, great. So building a partnership, that's first and foremost when working with our clients and learning from them about the contract management process and negotiation process. These are the four key elements that they share with us that are important to really forming a solid partnership with that payer. You really want to not just negotiate a contract and never speak to them. You really want to form that partnership. So first, what you can do is you can make your relationship easy. and ease of doing business. And that's just as granular as having your addresses up to date, your billing addresses, pay to addresses, any names, any just company information correct in their system, actively reaching out so that they have the most accurate information, so that when you do either open up a contract, when you do decide to open up that contract, they have all the right information on file. It's not this big cleanup project for them. That's important. Second is your engagement. So we want to know what you want to know, have a good understanding of what your demographic is, what patients you're serving, what market you're in. Are you in a saturated home health market? Are you one of few providers that's in that market that may have be providing these home health services or other services that are about to be covered by MA. So that's key. They're looking at that as well. And secondly, your participation in all products and scope. So they don't want you picking and choosing what plans you want to be a part of. They're often looking for partners to engage in their Medicare Advantage, their commercial, their managed Medicaid exchanges, everything like that. And also looking forward, the willingness to participate in new products or new networks that they're setting up, especially as we move forward and at one point in the future, not sure when right now, but those hospice products or hospice networks that they're opening up. Do you have a willingness to participate in those? Third, value is going to be what we repeat over and over again. The quality scores are what are driving and reduction in costs is what is driving MA's goals right now. So understanding what your quality scores are, what your patient satisfaction measures look like, what's your rehospitalization rate looking like, and really tracking and aggregating that data so you have something to show when you are opening up these negotiations or starting a brand new negotiation with a payer. And lastly, be a resource for this payer. Know who your network provider rep is. Have an internal, contract management resource that is has that relationship with your provider representative, so that as service lines are expanded, such as hospice and some of the non-skilled home care, you can be they can look to you to provide education, how your operating models, what they look like for those businesses as they're starting to learn about how they should reimburse these models. And really strengthen that relationship so that you're a phone call away. Any questions they have, they know that you're a good resource to turn to. All right, so we have our information about our costs, about our desired margins. We have we know what we need to do to form a great partnership with the payer. Now we want to talk about some of the specificities of the actual negotiation process itself, some of the terms you want to look at. First here is contract renewal time frame. If you can, it is best to negotiate that 2-year, 3-year, the shortest time frame you can for renewal, so that it gives you an opportunity to renegotiate your rates at that time. If you have an evergreen contract, you may forget to open that up for another 7-10 years, and at that point in time, it's much harder to obtain get to from $80 to $100 or $100 to $120 than it is to receive those incremental increases every 2 to 3 years. So that's really key, something that you want to look at. We talked about understanding what your target margins are, negotiating those rates. I just had a client who was going through this process. The payer came back and said, these are our standard rates. We have no movement on it. We cannot go any higher for you. They went back and said and negotiated and pitched some higher rates, and then they actually got a couple of dollars increase. So really charge forward with that negotiation, put those higher rates out there and see what you get there. And if you have some specialty programs, brag about yourself. If you are offering a great cardiac program or you have some great, you have a care management program for complex illnesses, prevention programs, anything that you have set up that's improving the quality of care for potentially specific types of patients, we'll educate the payer on what that is, and that can be kind of part of your contract. Maybe you can set up a program where they reimburse a certain type of visit under these programs, or you're demonstrating that improved quality of care, so they're willing to work with you on a couple of other conditions. And lastly, very connected to everything that David was speaking about, ask about potentially adding a value-based or risk arrangement to that contract. This is an potential opportunity for additional revenue if you are not obtaining the standard rates in which you would like to achieve those desired margins. You want to make sure that with these value-based and risk arrangements that you do have the internal resources to manage these, track your data, and that they are not, the cost is not outweighing the potential additional revenue there, but a great way to tie in, patient satisfaction, quality scores to some potential additional revenue. And the last part we wanted to talk about was more of the technical aspect of contracting with MA plans and managing those contracts internally. A tool that we have set up with our clients, we recommend any agency to set up to actively manage their contracts, is building a payer matrix. This is going to house all of your contract information. It is beneficial to multiple different departments in the organization, from an intake perspective, where you're just solely documenting the MPIs and branches that are contracted with those different payers and plans, a crosswalk to your EMR so they know what payers in the EMR can accept the different patients under those branches. From an authorization standpoint, it's certainly beneficial to outline any specific authorization requirements. Is auth required, not required? Maybe it's just required for aids at a certain time point, so that you're keeping all of that information housed and centralized. For billing, it's key to document the rates. Also for your contract analysis, obviously you want those rates documented, but it's going to be helpful for billing when they're going through the collections process to be able to compare back to what is contracted. Your timely filing limits are going to be important to monitor. Brian's going to touch upon that, how it'll be timely filings key for some of the operational management. And lastly, for your contract management team, what is some of the language that's in there? What is your contract effective date? What is that term language? What is some additional contractual language? And very important, what are your credentialing timeframes so that you can keep up with those and not be missing those? So Payer Matrix, great tool. Connected to that, we want you to keep an electronic contract repository with copies of all your agreements. So many times, we work with clients and their paper agreements from 10 years ago are at a copy in somebody's desk who may have, is no longer with the organization, and they're not quite sure where they are. They're having to reach back out for copies of their contracts. That's not ease of doing business if you keep reaching out for a copy of your contract. So obtain electronic copies, scan those paper agreements, house them in a central location, come up with a standard naming mechanism for these files, a naming convention for these files. I also can't tell you how many times we've pulled up contracts or been looking for contracts and the file name is like 5678 RAT, and that's just how maybe the file name came over 10 years ago, and it's difficult to identify and locate those contracts. So come up with a standard naming convention, track that name in the payer matrix as well, so you always have a great reference point, and those contracts are easily identifiable and easy to locate. And lastly, just management of your agreements. You want to be seeking out a fully executed copy. Sometimes either the payer has signed it or the provider has signed it. So really trying to get that fully executed copy on file. We talked about a little bit before with the and contract analysis portion. If you kind of want to start this new project, you're thinking about renegotiating, you have a large amount of MA volume coming in, look at some of those aged agreements, the volume associated with each of them. It may be time to renegotiate those, but you have to consider, is it worth it to renegotiate, or are you going to have to make that decision to term? What are your margins look like? What admissions are you referrals are you receiving for these different payers and plans from your referral sources? So have those conversations and keep up with and actively analyze these contracts. You also want to keep track of your payer mix balance. Make sure that you have a healthy mix of Medicare Advantage, commercial, your managed Medicaids, so that you are able to accept a large variety of patients from your referral sources, and you can balance maybe some of those lower rates with higher rates in different types of products. And I already mentioned this, but it's great to hammer home because I have a sad story of one of my clients. They weren't keeping up with their credentialing. They didn't know when their time frames were. A large payer source of theirs termed the agreement, and then when they went to go open up that contract again, the payer had a closed network and they were no longer accepting new contracts with providers. So that was just because of poor contract management and understanding of their credentialing timeframes and the different conditions for that contract. They lost a big one. So that's super important to monitor and something we want you to be aware of. So that being said, those are a few tools and strategies for working with the payers, managing those contracts once you get them in place. Brian is next going to speak about some of those operational considerations with MA plans.
Thanks, Sam, and thanks to David before that. Like Sam mentioned, I'm going to bring things home here and then want to leave a couple minutes for some questions. But want to talk about, okay, we know that Medicare Advantage is expanding. We've negotiated the contract. Now, what do we need to consider operationally? And we're going to look through different parts of the revenue cycle for that. Like you can see with the wheel here, authorization, documentation management, billing, collections, and reporting are some of the key areas. Obviously, they extend to really all parts of the rev cycle and even care coordination at some points, but we're going to look at these key areas here and tie it back to some of what we've talked about already. Starting with authorization, this is obviously a piece that's different with Medicare Advantage compared to traditional Medicare. Is in most cases with Medicare Advantage, not all, but most, you're going to need to request and obtain authorization before you deliver the service, and if you don't get that, then you're not going to get paid. So really important to take a look at this and make sure that whatever team you have working on this, whether it be an intake or a separate authorization and insurance team, that you're looking and monitoring these very closely, both start of care and recurring authorizations. A lot of times what we see is the start of care process is strong, but it's those recurring when you use up your initial visits and then have to get some additional ones where that kind of falls off. So some of the recommendations we have there, structuring assignments by payer. Sam mentioned a little bit earlier about building relationships. It works the same with the authorization, and you can build relationships with those authorization reps. You know who you're calling, they know you, you're able to work through things if you have any issues. Building those relationships and understanding the different payer nuances are key. We see some payers that you can operate through portals. We see some payers that you have to make calls, some payers that you have to fax hard copy things in. If you have staff that understand things by payer, know those nuances and are tracking those in that payer matrix that Sam mentioned, they're going to be able to more effectively go out, get that authorization, and make sure things don't fall through the cracks. Optimizing the EMR is obviously key. You can build any of these payer rules into your EMR so that there's different alerts that prevent you from missing these, and especially with that recurring authorization, letting you know when you need to request additional authorization, the typical time frames it takes to get those back. That's going to be very important as well. That's the technology side to compare to the process that we talked about there of build a process where you know what to look out for, then use the technology to help you really track that and stay on top of it. Tying back to the contract negotiation piece that Sam was talking about, negotiate favorable protocols. I mean, that's going to be the case with all of these here. We talked a lot about rates and rate setting and what the Medicare Advantage plans are looking for. But if you're hitting a barrier with rates, if you can negotiate more favorable protocols that lower the back office cost on your side, make it easier to go through these revenue cycle pieces, lower the bad debt that you're going to have due to missing authorization or some of the other pieces you're going to talk about, that in some ways is taking things in the same direction as a rate increase. So if you can negotiate, we've seen some Medicare Advantage contracts where you get 5 visits up front, and you don't need to request that at the start of care, but you know in the hustle and bustle of the start of care process, you have those 5 visits to rely on, and then you can just focus on going beyond that. So make sure you're keeping these types of things in mind as you're going through those contract negotiations. Same thing with the orders management and timely filing in general. We see this as one of the biggest holdups to getting claims out the door. If you have a tight timely filing, that could pose an issue, especially we saw with everything going on with the PHE this year in highly impacted areas. That in a lot of cases extended the time frame to get back those order signatures from the physician. So make sure you're paying attention to that. I mean, just in general, looking at it at its highest level, on the Medicare Advantage side, we typically see that they have signed orders as a requirement for billing, but not always. For the Medicare Advantage, that's going to be tied to your contract. So try to negotiate that in there. I mean, obviously we need those signed orders for compliance purposes and for the COPs, but in some cases you may be able to negotiate in your contract that it's not a requirement prior to getting billing out the door. So something to take a look at when you're having those conversations, and really looking at the timely filing. I was working with a client recently that had a couple Medicare Advantage plans with a 60-day timely filing, and they were seeing a lot of cases where they weren't able to bill in time because they were having trouble getting the orders back, sign within those 60 days, and then get the claims out the door. When they went to the negotiating table, kind of like what we talked about, they weren't able to get too much in terms of increased rates, but they were able to increase that timely filing limit from 60 days to 120 days. So it gives you a lot more breathing room and really reduce their bad debt because they were able to get the claims out the door timely and get those paid without dealing with a really tight timely filing. So that ties into the orders management, authorization, kind of everything we're talking about here. But wanted to give you some ideas of some things to look at outside of just the rates and costs that you can talk about when negotiating these contracts. And as we can see, it can help out with that bad debt and some of the revenue cycle processes and efficiencies there. Looking at billing and collections in general, this is one of the big things that we saw in home health in 2020. We know we moved to the patient-driven groupings model, PDGM. Traditional Medicare was pretty straightforward, but where we've seen a lot of complexity is on the Medicare Advantage side. We saw different variances and still continue to see that in how the Medicare Advantage plans are reimbursing across the country. Some are fee for service, some stayed with the old PPS episodic model, some moved to PDGM, some are doing a mix of all 3 of the above that we're still trying to figure out with some of our clients. So the key here is really to build that relationship again with account representatives so you can have that conversation of here's how we're billing the claims, here's the denials we're getting. There was a big change in the reimbursement model for traditional Medicare. What are you looking to see on the Medicare Advantage side with your plan to allow us to bill effectively? That's going to be huge, as David talked about, Medicare Advantage expanding into new service lines, expanding into hospice, expanding into some of those non-skilled, the home care side, where these Medicare Advantage claims or plans are processing these claims for the first time. So there may be some bumps in the road there. I mean, we're going to need to provide some education as to how traditional Medicare is operated or some of the other plans have operated, but it's going to require close communication with the plan and really a close eye on how we're billing and how we're performing our claims follow-up to understand what exactly do we need this claim set up to be to get paid for these new services. A couple recommendations for that, really just making sure you're tracking your denials and quantifying them. If we're saying that it's an issue because of the new PDGM HIPS code, is that 2 claims for $500 or is it 100 claims for $20,000? I mean, it's really important to quantify and see the trending issues and see the scope of the impact. And then going back to that technology piece, adjusting your EMR setup. If you're finding that there's issues with how claims are going out, making sure that you're changing that setup in your EMR, changing that payer setup, making sure that you stop the bleeding of these denials and get claims going out correctly the next time around. Same thing with the clearinghouse. You can set up a lot of rules with your clearinghouse where if you know specific codes are needed on the claim, you can set up alerts to stop at the clearinghouse if those are on the claim, or even just update the claims in some cases to add those codes in. So really important to take a look at that, and then again, leverage process and technology to make sure the claims are getting out cleanly. From collections, we always recommend strategizing by adjudication time. You want to make sure that your collections team is really being used effectively and not just spending a lot of their time doing claims follow-up, tracking, processing. You really want to focus on things that have been adjudicated and really focus on denials or any issues with payment. The exception in this rule might be with what we just talked about above with the billing. If the Medicare Advantage plans are taking on a new service line or are dealing with something like a PDGM implementation, which is huge, you might want to shorten that follow-up time just to see how things are processing. Take a little bit closer look for rejections, or maybe make a call to the payer a little bit earlier after your first batch of billing to say, hey, we submitted our first hospice claims to your Medicare Advantage plan. What are you seeing? Are you anticipating denials? Try to get out ahead of that, knowing that sometimes these processing times can take up to 30 to 45 days. If you can get working on any claims issues sooner, you can get out ahead of that, make those fixes that we just talked about, and then go back to your standard follow-up times in the future. Going back to that concept of education as well, this is kind of a two-way street. I mean, I'll use the PDGM example again, that us as providers, we were learning PDGM, we were learning how to bill, we were learning some of the nuances. As these plans take on PDGM for the first time, they're going through the same thing. So let's make sure we keep a strong line of communication, really educate those payer reps, build those relationships, talk through the denials, talk through what the expectations are set by Medicare, and that should help with the collections effort moving forward. And as part of that, initiate payer projects where necessary. Again, if you're seeing a wide scope of the same issue, rather than having your team go individually and send appeals for every single individual claim or rebuild a corrected claim for every individual claim, can we set up larger projects? We have that relationship, we have those conversations going with the payer reps. Let's try to get a mass rebuild of this. I mean, and again, for them, it can go back to that ease of doing business of, hey, we're working together, we got this fixed, and it's less they have to look at individually on their side as well. From a financial reporting standpoint, what we see a lot when we're working with some of our clients in financial analysis, strategic planning, is that they lump in Medicare Advantage and traditional Medicare into one line on their financials, and it really makes it difficult to analyze this. I was working with another client recently that was doing this, and we saw a really high volume of adjustments, and we couldn't figure out where it was coming from. What we did first was split it out by payer category, and we found that pretty much all of the adjustments that we couldn't explain were on the Medicare Advantage side, and it was due to some of the payer setup pieces that we just talked about a couple minutes ago. So by focusing on the Medicare Advantage, we know that there's going to be some different nuances to that, especially compared to traditional Medicare and some of the other commercial plans. So really isolate it, take a look at Medicare Advantage, see what sort of issues you have going on there, and make sure you're forming your strategic planning based off of that. We do expect a higher volume of aged claims and a little bit longer processing time with Medicare Advantage. We know with traditional Medicare, we might see 10 to 14 day turnaround. And again, with Medicare Advantage, that could be up to 30 to 45 days. So make sure you're reserve accordingly, knowing that we're going to have some of these issues, some increased denials. Typically, we look at, again, aged claims. So claims aged over 90 days in the AR, we look at a benchmark of 20% for that for non-traditional Medicare versus maybe a 10% for traditional Medicare. Same thing with the DSO, our benchmark for that is 75 days, a little bit higher than what we typically look at for traditional Medicare. I will say with that, I mean, the benchmark is 75 days, but we see some providers operating efficiently and are down in the 50s. So benchmark should be where you should start, and then once you get there, keep rising above that. But at the same time, and tying in with that, understand your cash flow trends and set up specific adjustment codes. Going back to that example of the adjustment issues I talked about a second ago, is make sure you have the ability when looking at adjustments to say, these are Medicare Advantage adjustments, let me look at these versus traditional Medicare versus a commercial versus maybe a Medicaid managed. Really look at it by payer category. As we've talked about over the last hour, the Medicare Advantage is going to have some unique nuances and potentially issues compared to some of the other payers. So you really want to look at that and take everything we talked about and apply it to your reviews here. So with that, I want to close things out with some key takeaways, and Sam and David, feel free to jump back in if I do leave anything out here. But summing up everything we talked about in the last hour, again, this Medicare Advantage expansion, it isn't going away. We view this to some degree similar to the PDGM conversations we were having last year. And some people were kind of asking the question, is this coming, is it not? It's coming, and with Medicare Advantage in a large way, it's already here. I mean, we're seeing the growth, we're seeing the expansion of different service lines. So make sure you're looking at the current and future state of how your organization is handling Medicare Advantage and really work that into your strategic planning, especially if you're operating in some of these service lines that Medicare Advantage is taking on for the first time. Sam talked a lot about knowing your worth as a provider. We know based off of what David was telling us what Medicare Advantage plans are looking for, how can your organization fit in with those conversations? How can you build that partnership and really help provide that high quality care at the lowest cost? Understand specialty programs that you do well. Understand the market share that you have if you're serving a large population. Understand what you do differently than the other providers that are in your space, and really make sure you bring that to the table rather than just going and saying, we have low rates, we want higher rates. Really state that case, and to Sam's point, brag about yourself where you can. To that point, be informed and negotiate accordingly. Again, take this information. There's a lot of other information around the industry. It's a hot topic right now, a lot of conversations going on. Make sure you take the information that's out there and use that as leverage when you're having these conversations to state the best case that you have for both increased rates on your side and any of the revenue cycle pieces we talked about that could help out with authorization or timely filing limits. And then closing out, just understanding that Medicare Advantage is unique. Again, there's a lot of nuances to this that you don't see even in traditional Medicare. Understand how that's different and understand how you need to operate as an agency to make sure you're successful under that. So with that, I'll kind of open it up. I know we want to leave a couple minutes for questions, which I believe we did here. So if there are any questions, I'll turn it back to Bob for that.
All right, thank you, Brian, and thank you, Samantha and David, as well, for that fantastic information. We do have a few minutes here for questions, and if we go a little bit over 2 o'clock, I think that's okay, because we do have a lot of them that have come in so far. David, why don't we go to you first and hear from you again? And I'm going to try to mesh 2 questions together here. So the question is, how do I find a Medicare Advantage plan in my market? And then along those lines, somebody just wants to know, what's the first step toward obtaining a contract and starting the conversation in the first place?
So absolutely. So looking in the market, again, going to the CMS and understanding who's in your market is one of the first things. Probably the second thing is really talking to your referral sources and seeing where, trying to align with them, because once you make that strategy and you move to that, you want all of the parts of the pieces moving together with that. I think the other thing is really going and doing a little research on the plan itself and figure out what they are doing and trying to figure out where they're going. We've all mentioned the little components of it, and I think it's very important. You have to look at this more than just traditional Medicare, because these plans are offering different types of services. And I'll use telehealth since that's really a key component. If telehealth is an important part and they're paying for it under the Medicare Advantage program and you're not offering it, then that probably puts you at a disadvantage. So offering services like that help supplement what their programs and plans are, I think is a key component. And leading up to, I think that's how you get into the door. I think that's how you have those conversations, is you have researched them, you understand that you have a good component of it, you have already some component of it moving through your agency or through your referral sources, and you have programs that align with them and you understand how to align with them. I think that's how you have the first conversations.
All right, thank you, David. Samantha, let's send this question your way. And again, I'm going to try to combine 2 here. Somebody wants to know, how do you draw the line at whether a contract is worth taking? And then again, related to that, somebody says that they're contracting with an MA plan that hasn't budged in terms of their rates in 3 years. How do you maybe move the needle when it comes to renegotiating rates with a plan you've been working with?
Sure. So the first question there, how do you know when to draw the line? One of the topics we discussed was just being informed about your internal financials, figuring out what your preferred, accepted, discouraged, and then completely unacceptable margins are. See where that falls. If it falls on the lower end, which is probably why you're trying to decide whether you should take the contract or not, look at those other terms alongside it, and what type of, such as timely filing, authorization, if you can get into some value-based arrangements that will give you that additional revenue. And also looking at what type of business is it going to open up for you from your different referral sources. What type of volume is it going to bring in? Can it bring in additional business because you're opening up that plan? And working with the MA plans that are just not willing to renegotiate, I think along the same lines, getting creative about any different arrangements that you can add to that contract that are going to potentially drive additional revenue. What information are you presenting to them when you're asking for these renegotiations? Are you presenting any sort of data about your quality scores, patient satisfaction measures, rehospitalization rates, specialty programs you have? Make sure that you're providing them with the full picture on the value in which you're serving that population. And so I think I would start with some of those tactics first.
All right, thank you as well. And Brian, to wrap things up, let's send one more question your way. What recommendations would you give a billing department that is submitting claims for a particular service line to a Medicare Advantage plan for the first time?
Absolutely. So we touched on it a little bit going through the presentation, but it's really proactiveness. It's again following up maybe a little bit sooner, paying a little bit closer of attention to individual claims as they process through, and really getting that conversation started with your payer rep sooner rather than later. Again, even if you look on a portal and see the claim is processing, you know it's been 15 to 20 days, maybe reaching out and having that conversation and saying, hey, we submitted our first batch. This is the first time we're billing your plan for this service line. Can we talk through what you're seeing? Can we talk through what you've seen with some of the other providers that are billing there? Again, try to figure out if there are going to be issues, figure that out on day 15 rather than day 45 to 50. And you can get out ahead of it and make sure you fix that before you send any other new claims out.
All right. Well, I think that is a good place to wrap up for today. Thank you to all our wonderful speakers. And again, thank you to Axxess for bringing this webinar together. And of course, thank you all for tuning in. If you did miss anything, again, you should receive a copy of the slides and a recording of the webinar within the next day or so. So be on the lookout for that in your inbox. But that's all for now. Have a great rest of your day, and thanks again.
Thanks.
Thanks, everyone.
Thank you.